In this video, we describe how to dissect the chambers of the heart and how to dissect the lungs. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. Blaise Pascal wrote in Pences, "The heart has its reasons which reason knows nothing of. We know the truth not only by the reason, but by the heart." What is it about this organ? Nothing more than a simple mechanical device, a mere pump, that has led thinkers for millennia to ponder about its magical powers. The answer is simple. The heart is life. Without it, game over. And by the way, the same can be said for the lungs. Let's start the third dissection of the thorax. This time we'll focus first on the heart and then dissect the lungs. Before proceeding to dissect the heart, we look at the heart in situ as shown in this slide. The first thing we notice is the appearance of two arteries, known as coronary arteries, because they sit on the heart as if they were a crown on it. Corona is a Latin word for crown, not beer. Generally, the two arteries that supply the heart muscle, that is, the myocardium with blood, are the right and left coronary arteries. The actual left coronary artery is hard to see, and instead we see one of its principal branches, the left anterior descending branch, or LAD for short. The anatomical name for this artery is the anterior interventricular artery. These arteries and accompanying veins are normally embedded in fat, which has been removed in this specimen. These arteries may become occluded with arteriosclerotic plaque, resulting in heart pain, known as angina, and/or heart attack. Indeed, because the most frequent site of coronary artery blockage is at the anterior interventricular artery, it has been given the name of the widowmaker. After removing the heart out of its thoracic cavity, we begin its dissection in the same order that blood flows in it. Blood will enter the right atrium from the superior and inferior vena cava. Note the inferior vena cava cannot be seen from this angle. From the right atrium, it will enter the right ventricle and leave by way of the pulmonary trunk. Blood will return back to the heart from the lungs via the pulmonary veins to enter the left atrium, then enters the left ventricle, to ultimately exit via the ascending aorta. You should become familiar with the orientation of the heart chambers from this perspective. Note that the right atrium forms much of the right border of the heart, the right ventricle forms the anterior margin, and the left ventricle the left border. The left atrium is at the back of the heart. Rotating the heart some to the left, we now look at the right margin and observe the superior and inferior vena cava, which both drain to the right atrium. The dissection begins by using scissors to open the right atrium by cutting in between the two vena caval openings. Each chamber of the heart of a formalin-fixed cadaver is usually filled with a blood clot, which must be removed. The clot that was in the right atrium is shown here. Also observed in this image are the pectinate muscles, which are located in the right auricle region of the right atrium. At the back of the right atrium is a depression known as the fossa ovalis. It corresponds to the foramen ovale, which in fetal life shunted blood from the right atrium to the left atrium to bypass circulation to the lung. If the flap covering the opening does not seal properly, blood may escape through here in postpartum life and will be heard as a murmur. Also at the back of the right atrium, we can find an opening where the coronary sinus drains. The opening is near the opening of the inferior vena cava. The probe in the image is indicating the coronary sinus just at the point where it is entering the right atrium to the left of the opening of the inferior vena cava. Blood flows from the right atrium to the right ventricle through the right atrioventricular or tricuspid valve. The location of the tricuspid valve is now indicated by the probe. The tricuspid valve is shown at higher magnification in this image. Note, most cadaveric hearts will show significant variations from the ideal depicted in an atlas. Heart disease remains a major cause of death in the civilized world, and variations in the appearance of valves, especially in the embalmed heart, will be significant. We then move to dissect the right ventricle of the heart and note that the right ventricle makes up most of the anterior surface of the heart. As shown in the image, we use a sharp scalpel to make cuts in the right ventricle and open it via incisions in its front surface. Once again, we remove a large blood clot from the chamber, and oftentimes, removal of the clot will destroy the delicate structures found within the chamber. Within the chamber of the right ventricle, we can now see the muscle of the ventricular wall, known as the trabeculae carneae. A prominent anterior papillary muscle is often present, which functions to maintain pressure on the valve cups. Much smaller septal and posterior papillary muscles can also, at times, be discerned if one looks for them. Difficult to see in this example is the septomarginal band or moderator band, which transmits the electrical impulse from the heart wall to the anterior papillary muscle. We'll see another example of this band shortly. And here's a good example of a moderator band extending from the interventricular wall to the base of the anterior papillary muscle. The papillary muscle is attached to the cusp of the tricuspid valve by the chordae tendineae. Realize that the function of the chordae tendineae is not to pull on the valve cusp to open them. They apply tension to the underside of the cusp so that the cups do not prolapse back into the atrium during ventricular systole. As the papillary muscles contract, they shorten and in turn keep the valves from reverting into the atrium. This would be noted by hearing a murmur. Shown here is a different heart dissection. Observe the prominent anterior papillary muscle, but also a relatively prominent posterior one as well, with an almost trivial septal papillary muscle. Expect variations in the appearance of papillary muscles. Note also the relatively clear moderator band in this heart. Finally, note the opening of the pulmonary trunk, which delivers blood towards the lungs. Given that the direction of blood flows away from the heart, the pulmonary trunk is an artery, albeit one that carries deoxygenated blood. Looking at the pulmonary trunk from below, we can now see the pulmonic valve. The valve consists of three cusps, the right, the left, and the anterior cusp. We now look at the posterior surface of the heart. The left atrium forms most of the posterior surface of the heart. Distinguish it from the right atrium and the opening of the inferior vena cava, and realize what is just posterior to the left atrium, the esophagus. This might help you to understand why heartburn or painful esophagus from acid reflux can be easily mistaken for a heart attack. From this posterior view, we can also detect the openings of the right and left pulmonary veins. These are called veins because they are returning blood to the heart, albeit they are delivering oxygenated blood back to the heart from the lungs. We can also detect a ridge-like structure that resides in the sulcus between the atrium above and the left ventricle below. This is the coronary sinus, which shunts venous blood from the myocardium to the right atrium. To get a clearer view of the relationship of the left atrium to the right atrium, we have placed probes into the right and left pulmonary veins and into the superior and inferior vena cava. Familiarize yourself with this relationship. The left atrium is opened by cutting between the openings of the right and left pulmonary veins, and again clotted blood needs to be removed from inside the chamber. Within the left atrium, if one looks inferiorly, we can now see the left atrioventricular valve, which is also known as the bicuspid or mitral valve, that separates the left atrium from the left ventricle. We begin the dissection of the final heart chamber, the left ventricle, by identifying the ascending aorta and pulmonary trunk. This chamber is then opened by cutting downwards along the aortic wall and the anterior wall of the ventricle. The much thicker wall of the left ventricle, compared to that of the right, is readily apparent once the wall is reflected. The left ventricle, similar to the right ventricle, has papillary muscles and chordate tendonae that link the papillary muscles to the mitral valve cusp. The action of these muscles and the function of the chordate tendonae are identical to those described for the tricuspid valve. The splayed open ascending aorta reveals the three-valve cusp, and also the sinuses of the aortic valve. Two of the three sinuses, the right and the left, have openings for the origin of the main coronary arteries. You can put a probe into these openings and push them into the two main coronary arteries. The four chambers we have just discussed in the series and associated structures are now shown in the image. Let's move over to the lungs just after we have removed them from the cadaver. Here, we see the normal model appearance of the external surface of the left lung. The dark splotches are due to inhaled particles and perhaps smoking in this person. Here we see the costal surfaces of both lungs, and we can observe certain features. Both lungs have an oblique fissure which separates the lungs into an upper and a lower lobe. In addition, the right lung has a horizontal fissure which separates the upper lobe into an additional middle lobe. Although the left lung does not have a true middle lobe, it does have a prominent outpocketing known as the lingula. The mediastinal surface of both lungs is dominated by the hilum and all the structures that enter and exit the lung at this location. These structures include pulmonary arteries and veins and bronchi. On the left lung, the pulmonary artery will be superior to the left main bronchus and the pulmonary veins will be anterior to it. If you have difficulty telling them apart, look for the presence of cartilage on the main bronchus. We can again observe the same structures on a hardened, well-embalmed left lung. The location of the pulmonary artery, veins, and primary bronchus are constant and can be used for identification purposes. But now we can also note a certain depression on the surface of the lung, such as the cardiac impression anterior to the hilum of the lung. Whereas posterior to and arching over the hilum is the impression of the descending aorta and the arch of the aorta, respectively. For the connoisseur, the impression of the left subclavian artery can also be discerned. Moving now to the hilum of the right lung, We can also observe the pulmonary veins, pulmonary artery, and primary bronchus. As with the left hilum, the location of the cut vessels and bronchus can be used to identify them. In fact, the primary bronchus of the right lung is above the right pulmonary artery and is referred to as the epiarterial bronchus. Depressions on the well-embalmed lung can also be discerned and can be used to identify the location of the inferior and superior vena cava, the locations of the right brachiocephalic vein, and the arch of the esophagus. Finally, the location of the trachea and the esophagus can also be discerned in the mediastinal surface of the lung by the depression that these structures leave on it. The next step in the dissection is to carefully begin to remove the lung parenchyma and the arteries and veins, but leave behind the bronchi. In time, it will be possible to observe the secondary bronchus of each primary bronchus, and if you continue removing lung parenchyma, even tertiary bronchi will become visible. Note the secondary bronchi are those that are emerged directly from the primary bronchus. In the dissection, the angle of view prevents a clear distinction of this relationship. Each secondary bronchus supplies one lobe of the lung. Tertiary bronchi, of which only one is indicated, supplies single bronchopulmonary segment. Note also how much larger and straighter the right primary bronchus is. This is one of the reasons that aspirated objects are more likely to end up in this bronchus. This now concludes the second dissection of the thorax.